Assalamu alaikum wa rahmatullahi wa barakatuh. Today our subject is about hypertension in pregnancy and its management. So our objectives as follow: types of hypertension in pregnancy, the diagnosis, the treatment, antenatal and postnatal, and timing for birth for those group of patients and the follow-up. So introduction. Hypertension is one of the most common complications during a pregnancy. Complicate about 5 to 10% of all pregnancy. And it's a risk for maternal and perinatal morbidity and mortality. It is one of deadly trait, hemorrhage, infection, and so hypertension is one of deadly trait. The trait are hemorrhage, infection, and hypertension. Most recent UK perinatal mortality report, they found that 1 in 20 means 5% of stillbirth in infants without congenital abnormality occurred in women with preeclampsia. 50% of women with severe preeclampsia give birth preterm. As you know, the first management of severe preeclampsia is termination of pregnancy. Hence, lead to preterm birth. A study in one region of UK reported that 5% of women with severe preeclampsia or eclampsia were admitted in ICU. Because we know all preeclampsia, severe preeclampsia, and eclampsia can lead to end organ damage. Maternal history at booking visit alone as a form of first trimester risk assessment for preeclampsia can protect 45% of cases of both early and late onset preeclampsia and 35% of cases of gestational hypertension. What I mean by these sentences that it's very important to take history to rule out whether this patient can develop preeclampsia or not. For example, if she has a previous history of hypertension, or she's a non-case of hypertension, or family history of hypertension. So there are many factors that can increase the risk of hypertension in a pregnancy, and we will explain in a while. So hypertension disorder in a pregnancy, either chronic or preeclampsia superimposed on chronic hypertension, gestational, that happened after 20 weeks of pregnancy, and preeclampsia. That means there will be proteinuria in addition to elevated blood pressure. I will explain one by one. So again, the hypertension disorder in pregnancy, the blood pressure higher than 140/90. This is the cut level, 140/90. Higher, we will label this pregnant woman as hypertension. So if this blood pressure higher than 140/90 before 20 weeks of gestation without proteinuria, so the patient labeled as chronic hypertension. If there is proteinuria with elevated blood pressure, this means preeclampsia superimposed on chronic hypertension. These are before 20 weeks. So before 20 weeks, high blood pressure without proteinuria, chronic hypertension. With the proteinuria means preeclampsia superimposed on chronic hypertension. Any patient elevated blood pressure 140/90, first investigation, urine routine to rule out whether there is proteinuria or no proteinuria. After 20 weeks of gestation, again, if with the proteinuria, called preeclampsia, with no proteinuria, called gestational hypertension. That means it's happened only during a pregnancy. So after 20 weeks, we find blood pressure high, again, we'll send for urine routine for albumin or protein. If it is positive, preeclampsia. No proteinuria means gestational hypertension. Always the prevention of preeclampsia or hypertension is very important to advise the woman and counsel her about lifestyle modification. How that's happen? By advise her on weight management, exercise, healthy eating, lowering the amount of salt in their diet. We will not tell her avoid salt to completely, no, just to reduce the amount of salt in their diet. Again, one of the prevention of preeclampsia is low-dose aspirin and calcium. So the prevention is lifestyle modification, low-dose aspirin, 75 milligram to 150 milligram, and calcium tablet. So according to the NICE guideline, the hypertension in pregnancy, the planning curve for women at moderate and high risk for preeclampsia, we have to assess the risk from first visit, as we say in the previous slide. So we have major risk and we have moderate risk. High risk, if the patient hypertension during a previous pregnancy, please start aspirin 75 to 150 from 12 weeks until birth. Please not stop it at 34 or 36. Continue until birth. If she has a chronic kidney disease, if she has autoimmune disease such as systemic lupus erythematosus or antiphospholipid syndrome, type 1 or type 2 diabetic, chronic hypertension. So any patient from history at booking, she has history of hypertension in previous pregnancy or chronic hypertension or chronic kidney disease or autoimmune or type 1 or type 2 diabetic, start aspirin. Again, I would like to emphasize on the word autoimmune. If the patient has history of thyroid, as you know, everyone, thyroid, hypothyroidism or hyperthyroidism, it's an autoimmune. So again, please start low-dose aspirin. They say here autoimmune disease, such as, that means there are another autoimmune, not necessary to be a systemic lupus erythematosus or antiphospholipid syndrome. But of course, for any patient with systemic lupus erythematosus and antiphospholipid syndrome, we should start aspirin. But any autoimmune, that's why type 1 diabetic also always will do hyperthyroidism. We will write aspirin because of diabetic. If the patient has high fasting blood sugar in first trimester, we will give her aspirin. Again, start from 12 weeks and until birth. The window for aspirin to be given is 12 weeks. Sometimes we forget to give it 12 weeks. You can give at 13, 14, or 16 weeks. After 16 weeks, there is no benefit, even though there is no harm, but it's preferred to be given from 12 weeks. So this is for high risk. What about moderate? Moderate if 2 or more. For example, first pregnancy, age over 40. If 2 of these, primary and above 40, start aspirin. If pregnancy interval more than 10 years, if body mass index equal or more than 35, if family history of preeclampsia or multifetal pregnancy, that means a twin or triplet. So, for example, let's say we have one patient called Sheikha. She is a primary gravida and a twin. I will start aspirin from 12 weeks till birth. Let's say I have one patient, she is above 40 and her body mass index more than 35 or equal to 35. Again, this is an indication to start low-dose aspirin. But age more than 40, equal or more than 40 itself alone is not an indication for low-dose aspirin, unless there's another risk factor like increased body mass index, there's family history of preeclampsia, or a twin, or primary gravida. So 2 of these, it is an indication to give aspirin. Again, they say if a previous severe preeclampsia or preeclampsia needed a birth before 34, as we say, the first line of management for severe preeclampsia is termination of pregnancy means that need birth before 34 weeks, or preeclampsia with baby birth weight less than 10 centile, or intrauterine death, or placenta abruption, please, we have to do ultrasound for fetal growth, amniotic fluid volume, and umbilical artery. We will start at 28, 30 weeks, at least 2 weeks before previous gestational age of onset of hypertension. If it is less than 28, and repeat 4 weeks later if it is normal. CTG only if indicated. For example, she has reduced fetal movement. In this way, we have to do CTG. So again, if the patient has preeclampsia less than, and she needed delivery before 34 weeks, okay, so in this way, I will start for her doing a scan at 28 or 30 weeks, or at least 2 weeks before previous gestational age. Means if she's 34, I forget to do growth scan at 28, I can do at 32. In this scan is very important to do growth scan, amniotic fluid index, and umbilical artery. And if it is normal, we can repeat it every 4 weeks. So for hypertension pregnant women, we have to assess from booking for need for low dose aspirin, because this can reduce the risk for preeclampsia and eclampsia. And we have to do ultrasound for growth scan and amniotic fluid index and umbilical artery Doppler for patient preeclampsia. What about calcium? We spoke here about, we say the prevention, lifestyle modification. This is, of course, you can advise and refer the patient to dietitian, as any chronic disease like hypertension, diabetic, anemia, please refer to dietitian. They can counsel and advise the women on the type of food that they can eat. And we say again, aspirin is one of the prevention, and calcium. So about calcium, WHO advised calcium supplementation at dose of 1.5 to 2 grams per day from 20 weeks. In population when calcium intake is low, to prevent the onset of preeclampsia, especially amongst women that are at high risk for preeclampsia. The reason that it's commenced at 20 weeks of gestation is that at this gestation, for which most evidence exists, it's most likely that this is when maternal level begin to fall. So any patient has history of preeclampsia, lifestyle modification, low dose aspirin, calcium in the dose 1.5 to 2 from 20, aspirin from 12. And they say at 20 because at 20 weeks, they found that the level of calcium reduced also. And if you remember, we say that gestational hypertension happen after 20 weeks. And most of eclampsia and preeclampsia happen after 20 weeks. So the doses 1.5 to 2 gram daily, and the duration from 20 weeks until the end of the pregnancy, like the low dose aspirin, 75 to 150 milligram from 12 till delivery, here from 20 till end of pregnancy. So now we will come to the classification of hypertension. We say chronic hypertension if blood pressure of 140/90 or more on 2 occasions. Please, you can check the blood pressure, we say twice, and the chronic hypertension, as we say, it's happened before 20 weeks. And also sometimes it's happened early in first trimester, but persists after 12 weeks. So this is a chronic hypertension. That's me, for example, one patient come to us and she has elevated blood pressure, but she is non-case of hypertension, but her blood pressure stayed after delivery 12 weeks. So this is labeled as chronic hypertension. So they're classified again, mild, moderate, severe. Mild, the systolic 140 to 149, diastolic 90 to 99. moderate 150, 159, diastolic 100 to 109, severe 160 over 110. For mild and moderate can be managed in OBD, but for moderate need more follow-up. For severe 160 over 110, please stabilize the patient and refer to the hospital for further management. So chronic hypertension, as we say, essential hypertension most common, secondary hypertension, sometimes genetic, renal, endocrine. These are the causes of chronic hypertension. Sometimes endocrine like Cushing, pheochromocytoma, primary hyperaldosteronism, and vascular like aortic coarctation and others. So if the patient, please ask on what medication the patient is on. For example, if she is on angiotensin converting enzyme inhibitors or angiotensin type 2 receptor blockers. So if she is on ACE or ARBs or chlorothiazide, advise her to stop these medication as they have teratogenic effect on her fetus. Baseline investigation is very necessary to be done for any patient with chronic hypertension and becoming pregnant. These are include renal function test, uric acid, liver function test, thyroid function test, and urine albumin creatinine ratio, and ECG. We have to do this in order to see if there's any end organ damage as a baseline investigation. So very important for any chronic hypertension, take history, on which medication, stop and change it to friendly medication that not affect on her fetus. And we have to do baseline investigation to see if there's any end organ damage. The treatment of chronic hypertension, again, if she is on ACE or ARBs or chlorothiazide, stop the medication and change it to methyldopa, labetalol, nifedipine. These are safe and friendly medication. And the aim is to keep the blood pressure less than 140 over 90. What about timing of birth? Timing of birth for those patients, chronic hypertension, we say, do not offer birth to women with chronic hypertension whose blood pressure lower than 160 over 110 with or without antihypertensive treatment before 37. That means it's very important to do the birth after 37. So after 37 weeks to be planned after discussion with senior obstetrician according to maternal and fetal indication. In refractory severe chronic hypertension, offer birth regardless of gestational age to save the mother. So any chronic hypertension, refer the patient at 36 weeks and the hospital will give the time, the mode of delivery for this patient. So again, management of chronic hypertension postnatal, she delivered the patient at hospital. They will measure blood pressure daily for first 2 days and again between 3 and 5 days after birth. This is very important to measure blood pressure also between day 3 and 5 after birth. Even if the patient is discharged after 24 hours, if she delivers normal, we'll advise her to measure blood pressure day 3 and day 5. If antihypertensive treatment is changed after birth, and here the aim is to keep blood pressure lower than 140 over 90, again, as we said previously, and review long-term antihypertensive treatment 2 weeks after birth. If the woman has taken methyldopa, please, methyldopa should not be given postnatal. It should be stopped immediately, and we can restart and resume the prenatal antihypertensive. For example, if the patient on ACE inhibitor and we change it to methyldopa, please advise the women that methyldopa should be stopped after delivery as it is not given postnatal. And again, for this patient, we will advise her to go back to her general medicine doctor 6 to 8 weeks after birth. So management of management of patient with gestational hypertension. Gestational hypertension, we say without protein. So if the blood pressure, we measure it more than 140 to 90 or 159 or, over 109. This is without proteinuria. This is gestational hypertension. According to the last edition of NICE guideline, the gestational hypertension will be divided into only two groups, either severe or hypertension, we call it, like mild to moderate, they put it in one group. So for severe hypertension, as we say, the blood pressure is 160 over 110, equal or more. Here, we say need to be admission to the and refer to the hospital. For mild to moderate, please, it's not necessary to be admitted to the hospital, can be managed in OBD, but regular follow-up. So let's say the patient mild to moderate, and again, we say the mild to moderate, the blood pressure range from 140, 159 systolic, 90 to 109 diastolic. Of course, you will start pharmacological treatment. The aim to keep blood pressure above 140 to 90 millimeter mercury. Aim for blood pressure 135 over 85 or less. Once, well, how much you will measure the blood pressure? Once or twice a week. So it's not necessary to measure daily. You can tell her to measure the blood pressure once or twice a week, depending on the blood pressure, until blood pressure 130 over 85. What about proteinuria? We will do once or twice a week, of course, with blood pressure measurement. What about blood tests? We will do liver function test, renal function test, uric acid. Here they say measure full blood count, liver function test, and renal function test, and presentation at the presentation, and then weekly. So I have one patient, for example, she is moderate hypertension. Every time she comes to me, for example, 150 over 100, I will start medication. I start, for example, labetalol 100 BID. Then I will double the dose after 48 hours. And I will ask her to measure blood pressure, as we say, once or twice a week. And also every time she comes to me, I will ask her to do a urine albumin. Regarding the blood work, we will do weekly. What about severe hypertension? Please, severe hypertension 160 over 110, refer her and as she needs admission. Because you know this is high blood pressure can lead to many consequences on the mother, on the baby. So refer to the hospital. The aim is to keep blood pressure less than 160 over 110, and they give pharmacological treatment. The blood pressure again to be reach 135 over 85. Here we say the admission, so the blood pressure need to measure every 30 minutes until the blood pressure is less than 160 over 110, and the urine albumin to be done daily, and the blood work to be done weekly. So it's very important for mild to moderate, not necessary to be referred to the hospital, can be follow up once, twice per week, but for severe need to be admitted to the hospital. This is regarding gestational hypertension, which defined as blood pressure more than 140 or equal or more than 140 over 90 without proteinuria. What about preeclampsia? Preeclampsia also defined as blood pressure over 140 over 90 with proteinuria. Again, they classified into mild, moderate together in one group and severe. Again, here they say hypertension, blood pressure 140 over 90 to 159 over 109. Admit if any clinical concern. Let's say I have patient blood pressure 150 over 109. Do I need to admit? Only if she has a clinical concern. What does mean? If she has headache, epigastric pain, visual disturbances, decreased fetal movement, or by scan, I saw small gestational age. So in this way, I will refer to the hospital. Otherwise, will be managed in OBD. So admit if any clinical concern for well-being of the woman or baby, and or if high risk for adverse events suggested by specific risk reduction models. But the very important point, just ask her if she has any history of headache, epigastric pain, visual disturbances, and ask about fetal movement. If there's no asymptomatic, only blood pressure high, you can offer pharmacological treatment to keep your blood pressure less than 140/90, and the blood pressure again at least every 2 days, and more frequently if she is admitted to the hospital. Dipstick proteinuria, because already we label the patient as a preeclampsia, which we say preeclampsia, there is high blood pressure with protein in urine. So only repeat if clinically indicated. For example, if a new symptom and side develop, if there is uncertainty over the diagnosis. For example, let's say the urine routine show urinary tract infection. Urinary tract infection sometime will show albumin 1 plus. So I just want to be sure whether this patient, she has this albumin due to urinary tract infection or due to blood pressure, high blood pressure. So in the second visit, after giving her antibiotic to manage urinary tract infection, I would do again urine albumin. If a plus, that means is not related to UTI. This means again, for sure, this is a preeclampsia. Again, full blood count, liver function test, renal function test twice a week. So in gestational hypertension, blood test weekly, but if preeclampsia, twice a week. What about severe hypertension? Again, like in gestational hypertension, please refer to the hospital as they will do the required investigation and adjust blood pressure and the management. And here the blood work, they will do it 3 times a week, not like in gestational, they will do it weekly. Gestational because no proteinuria, that's means there's no end organ damage, so just blood work will be done weekly. But here, if you see the blood work for mild to moderate twice a week, well, in severe, we will do it 3 times a week. So how we will assess the proteinuria in hypertension disorder of pregnancy? They can use automated region strip reading device for dipstick screening for proteinuria in pregnant women in secondary care setting. If dipstick screening is positive 1 or more, we can use albumin creatinine ratio or protein creatinine ratio to quantify the proteinuria in pregnancy women. Do not use first morning urine void to quantify protein in pregnant women. So let's say the patient has +1, okay? So we label the patient and we'll say this is patient preeclampsia. And it's better to do albumin creatinine or protein creatinine, but we'll advise to do it not in the first morning urine void. Do not use first, okay? So, and also do not protein use 24-hour urine collection to quantify proteinuria in pregnant women. So if we use the protein creatinine ratio to quantify proteinuria in pregnancy women, the cutoff or the threshold is 30 milligram per milliliter per millimole. If albumin creatinine ratio instead of protein creatinine ratio, the cutoff is 8 milligram per millimeter mole. So in primary healthcare is very important. Just see if it is +1, you can do albumin creatinine ratio and further investigation. But for severe hypertension, of course, you will refer to the hospital. Everyone know this is very easy for the symptom of preeclampsia. Always, if any patient with chronic hypertension or gestational hypertension or preeclampsia, advise her about to come as soon as possible to the health institute if she has severe headache or a problem with vision or severe pain below the ribs, or she has vomiting or sudden swelling of face. Sudden. Many women, they have swelling and edema of pregnancy in around 80%, but this is normal sometime in your trimester. So for every patient with hypertension, whatever the type of hypertension, tell her, please, if you have any headache, visual disturbances, epigastric pain, review as soon as possible to the primary healthcare, and also vomiting. What about the management? How I treat the patient with chronic hypertension or with gestational or preeclampsia? Again, we say if chronic hypertension, please stop ACE or ARBs, and the first line is labetalol. But please ask, if the patient has history of asthma, because labetalol not to be given in asthma. And sometimes it can lead to bradycardia in the baby. But however, this is the first line of treatment for any kind of hypertension in pregnancy. So you can start with 100 TID or QID or BID and increase the dose every 80 hours and see the blood pressure measurement. And according to the blood pressure, the maximum dose is 300 TID. QID means the maximum dose is 1,200. So first line labetalol 100, start like OD, BID, QID. You can even reach to 300, okay? But the maximum is 1,200. What about the second line? Again, we can say nifedipine or methyldopa. But for nifedipine, which is Adalat, please, is very important to avoid with aortic stenosis. And they can say we can start with 20 milligram, not necessarily 30 in our institute, and increase the dose maximum to 120. And again, always we say you can increase and double the dose every 48 hours. What about methyldopa? Methyldopa sometimes lead to maternal depression. That's why it's very important to stop methyldopa after delivery. Methyldopa only during pregnancy. Here, they can start 250, BID, QID, QID, maximum dose is 2,500 per day. However, let's say I have one patient on start with her labetalol. I start 100 BID, doubling 200 BID, then increasing to, for example, 200, 100, then 200, then increase to 200 TID. Means stepwise, and there's no improvement in blood pressure. It's not necessary you will double and reach the maximum dose 1,200. Sometimes you can consider adding another low dose medication rather than going to higher dose of the same medication. For example, I have one patient, now she is with me. I start with her labetalol 200, means I start 100 BID, after 48 hours start increasing to 200 BID, then 200 in the morning, 100 in the afternoon, 200 at night. However, I reached to her 200 TID, but I found her blood pressure not change at all. So I start for her nifedipine Adalat, 20 milligram OD, and now she is controlled. So according to your patient, and the management is individualized. Some doctors prefer to give methyldopa, but for high blood pressure, labetalol is working more. However, if the patient is asthma, I will not give labetalol. I will give nifedipine or methyldopa. But for me, if the patient asthma, I will give methyldopa. So what about severe hypertension? You can give IV. The IV is labetalol, for example. Again, we say would not be given to asthma or heart failure. And it's preferred to give the IV labetalol only to severe hypertension, and it's advised to be given in secondary institute. What about nifedipine? Nifedipine, please, they say do not bite the Adderall tablet. Sometimes lead to maternal headache and tachycardia. You can give 10 milligram and increase every 30 minutes to 30 milligram if the blood pressure not reduced. Methodopa, it's like, from my experience, it's not working for acute hypertension. Hydralazine sometimes lead to increased risk of maternal hypertension. So just regarding the management, we say labetalol starting 100 and doubling the dose every 48 hours, and the maximum dose 1,200, and you can add another medication to it, like nifedipine or methodopa. So in brief, we say the classification, the blood pressure, if mild or severe, and again, this depends also on, this is the classification for preeclampsia in pregnancy. So mild blood pressure less than 160 over 100, and the proteinuria will be like 1 plus, less than 5 gram per deciliter, 24-hour collection, but she's asymptomatic. And if you do liver function test or renal function test, it all will be normal. And it's very important to do CBC and focus on platelets, because some patients, they have mild elevated blood pressure, but you will find low platelets. So please put in mind that may be HELP, which is hemolysis elevated liver enzyme and low platelets. So some patients, there are platelets will be low and liver function test elevated, put in mind HELP. But in mild preeclampsia again, blood pressure less than 160 over 110, but asymptomatic, and all investigation are normal apart from albumin in urine. About severe preeclampsia, the blood pressure is more or equal 160 over 110, and all the liver function test, renal function test, there will be low platelets, all will be positive. Again, we say this, there's classification to mild and moderate. So this is again just definition for severe preeclampsia, which should be referred to the hospital, especially if they have sign and symptom, like we say severe headache or epigastric pain or IUGR, or even reduced urine output. So if we have severe hypertension we say is more than equal or more than 160 over 110, you can give nifedipine. So please keep in your clinic a nifedipine tablet, because sometimes it will work for severe hypertension, as it works onset after 30 minutes. So we can give her start with 10 or 20 and measure blood pressure after 30 minutes, please, to 45. And you can repeat after 40 minutes. For example, the patient blood pressure 160 over 110. Okay, I give her 20. I will tell her to have a rest and sit a while for 30 minutes. I found her blood pressure after 30 minutes is the same. So I can repeat the blood pressure again. I can repeat again the nifedipine, 20, but the maximum is 80 milligram. I just will stabilize the patient and refer to the hospital. So you can just give her nifedipine and see if she needs another dose. For example, even in the ambulance, if find blood pressure high, you can start another 20 milligram nifedipine. What about labetalol? For labetalol, you can start, I say IV, you can start initially 20 milligram and repeat with 40 to 80 milligram. The labetalol, we are always, for severe hypertension, we say we can give labetalol to reduce the blood pressure. This is the first line, as the onset after 5 minutes. And you can repeat after 10 minutes. So the first line for lowering blood pressure in severe hypertension, especially in secondary, they prefer to give labetalol IV. In primary, you are giving tablet, like starting 200 milligram labetalol tablet. Hydralazine also can be given, like 5 to 10 milligram, and can repeat it every 20 minutes. and the onset after 20 minutes. So you see that the labetalol is the fastest and can be repeated every 10 minutes. So this is the safest and better and first line of management for hypertension, whether mild or severe. So what the complication of preeclampsia to toxemia? There are effects on the baby, so there will be decreased fetal movement. And sometimes we say for any patient with the preeclampsia, we'll do a growth scan, amniotic fluid index, and umbilical artery Doppler, because sometimes you find reduced amniotic fluid, and there's increase in umbilical artery resistance. So always ask the patient if she has any symptom of headache, visual disturbances, epigastric pain, and also don't forget to ask about fetal movement. Again, now we have what about the fetal monitoring in patients with the chronic hypertension or gestational hypertension or preeclampsia? For a chronic hypertension, always we say we'll do fetal growth and umbilical artery Doppler 28 week, 32 week, 36. So from 28 every 4 weeks. What about gestational hypertension? The same thing. We will do ultrasound for fetal growth, amniotic fluid, and umbilical artery, but here we'll do it every 2 to 4 weeks, depend. If she's stable, I will give her every 3, 4 weeks, not necessarily every 2 weeks, but if the blood pressure high and she is still on stepwise management, I will do every 2 weeks. What about preeclampsia or severe hypertension? Here again is very important. For severe, here we'll do CDG, because one of the sign for severe preeclampsia, sometimes it will be variability change in CDG. There will be fetal abnormality on the CDG. So if there is, we'll do CDG cardiography, topography diagnosis of preeclampsia or severe hypertension. So if conservative management of preeclampsia or severe gestational hypertension is planned, carry out the following tests for diagnosis. We'll do ultrasound, fetal growth, amniotic fluid, and umbilical artery. If all normal, no need to repeat CDG. So for hypertension, we'll do growth scan, amniotic fluid index, and umbilical artery every 4 week. For gestational, the same. We'll do growth scan, umbilical artery Doppler, and amniotic fluid, but here we'll do from 2 to 4 weeks, more frequent. In severe, we'll start with CDG. If it is normal, just we'll do the ultrasound for growth, amniotic fluid index, and umbilical artery Doppler. If everything is normal, no need to repeat CDG. Just one point regarding the amniotic fluid volume. It's not necessary to measure the amniotic fluid index. You can measure the deep vertical pool just to rule out oligohydramnion, means reduced Likert. In women with preeclampsia or severe hypertension, we'll repeat cardiograph in case the woman has change in fetal movement. She has vaginal bleeding, if there's abdominal pain, deterioration in maternal condition. In women with preeclampsia or severe hypertension, repeat ultrasound for fetal growth, amniotic fluid volume assessment, or umbilical artery Doppler. So as we say here, CDG at the beginning, no need to repeat CDG, only if there is reduced fetal movement or vaginal bleeding or abdominal pain, or there is deterioration in maternal condition. So this is the same. We say that we will do again ultrasound for fetal growth, amniotic fluid volume assessment, umbilical artery Doppler between 28 to 30 weeks, at least 2 weeks before previous gestational age of onset, if earlier than 28 weeks, and to repeat it every 4 weeks later in women with the previous severe preeclampsia. Preeclampsia resulted in birth before 34 weeks. Preeclampsia with a baby whose birth weight was less than 10 centile, or IUFD or placental abruption. Already this is discussed in a previous slide. So again, just in brief, for any patient preeclampsia, the timing of birth, before 34 week, only if severe hypertension that can affect on the health of the mother. To save the health of the mother, we will do birth for this patient, but of course we give intravenous magnesium sulfate. From 36 to 37 week, here we should do a very frequent follow-up for this patient. When considering the option for planned early birth, take into account the women and the baby condition, the risk factor such as maternal comorbidity, twin, and availability of a neonatal unit bed. And of course, we leave dexamethasone if we are planning to deliver the patient before 37 week. 37 week, if the patient 37 week, we can initiate birth between 1 to 2 days. That means if the patient has preeclampsia and she came to us with at 37, we can initiate birth. If she is before 34 week and she has a preeclampsia and high blood pressure, we will, afraid from the patient develop eclampsia, we'll give her magnesium sulfate and deliver the patient. So this is individualized, and of course, this is the decision of the senior obstetrician at secondary healthcare. So what about postnatal? For any patient preeclampsia, we say it's very important for any patient preeclampsia who took antihypertensive treatment to measure blood pressure 4 times a day if she is inpatient, then 1 to 2 days for 2 weeks after transfer to community, means that discharge from the hospital will ask her to measure blood pressure every 24 to 48 hours for 2 weeks. The aim is to keep blood pressure less than 140/90. And then you can reduce the hypertension if the blood pressure less than 130/80. Let's say she is on labetalol 200 TID and blood pressure 130/80. So you can reduce the labetalol, not to stop it immediately. Stepwise reduction in her management. If woman was on methyldopa, please stop it within 2 days. As we say, methyldopa is not to be given to postnatal because already it will lead to depression, and in postnatal depression will be high due to hormonal factors. And we can hear postnatal women with preeclampsia are still on antihypertensive treatment 2 weeks after delivery. Medical review should be offered. You can refer her to general medicine. And all women who have preeclampsia should be seen by general medicine doctor at 6 to 8 weeks after birth. So this is the management for postnatal. What about the hematological and biochemical monitoring for any women preeclampsia, mild or moderate hypertension, or after a step down from critical care? We measure platelets count and LFT for transaminases and serum creatinine 2 to 3 days after birth. So let's say the patient has a preeclampsia and she is discharged from the hospital. Please will repeat LFT, uric acid, and platelets count 2 to 3 days after birth. If biochemical and hematological indices are improving but stay within abnormal range in women with preeclampsia postnatal, repeat platelets count, transaminases, and serum creatinine as clinically indicated, and also repeated after 6 to 8 weeks after birth. So any patient with preeclampsia in postnatal, we will measure blood pressure 1 to 2 days, and we will change the medication according to her blood pressure. We never stop immediately. We'll reduce the tablet to stop it. And we will do hematological after 2 to 3 days, and again after 6 to 8 weeks after birth. And any patient with a preeclampsia and still on antihypertensive treatment 2 weeks after delivery, please refer her to general medicine because this patient might develop hypertension. And as we did say, if the blood pressure stay high after 6 to 8 weeks, we will label this patient as a chronic hypertension because it's after 12 weeks, if blood pressure remain high, we label her as chronic hypertension. HELP, as we defined earlier, is hemolysis, elevated liver enzyme, and low platelets. So here, of course, if we find some patient with low platelets with high blood pressure and the platelets less than 100, elevated LFT transaminases, so please refer this patient to hospital because they will do further investigation, and the treatment here will be a multidisciplinary team. And if she is more than 34 weeks, they might plan for birth. For eclampsia, as you know, it's a new onset of seizure in women with preeclampsia preceded by increasingly severe preeclampsia, or it may appear unexpectedly in patients with minimal elevated blood pressure. So any patient with chronic hypertension or gestational hypertension or preeclampsia can develop eclampsia. And it's mostly happening antepartum, 53, intrapartum, 19, postpartum, 28. That's why we say in postpartum, the follow-up of blood pressure is very important. First 2 days and also in day 3 and 5. And we will keep the patient on the medication, will not stop it. And we have to do follow-up postnatal for this patient because still she is a risk for preeclampsia. So we say the eclampsia management here also, if she has severe preeclampsia and she has like visual disturbances, headache, vomiting, epigastric pain, reduced urine output. This is a risk for eclampsia, so we'll give magnesium sulfate as first line of management. And please, regarding the fluid, don't give all fluid too much. Restrict the fluid to 80 ml per hour. It's not necessary to give the patient eclampsia fluid. Just put for her cannula to IV line, but do not give IV fluid unless she has dehydration or bleeding. In this case, you will give IV fluid, but please limit the IV fluid to 80 ml per hour. So again, for eclampsia, we'll manage this patient. Again, put her in left lateral position, give oxygen, give 2 IV line, give her magnesium sulfate 4 to 6 gram IV bolus. If not effective, give another 2 gram. So the loading dose, 40 gram, should be given intravenously over 5 to 15 minutes, followed by an infusion of 1 gram per hour, and keep it for 24 hours. And very important, the dose is 40 gram, and still the patient has eclampsia, give another 2 gram as a bolus within 5 to 20 minutes, 15 minutes. Then you will give infusion, at least keep it 24 hours because the risk for eclampsia postnatal is also high. So it's very important, please, in your primary healthcare to see whether you have magnesium sulfate or not. And also, you must have calcium gluconate as antidote for magnesium sulfate. Let's say the patient comes to you and she has like visual disturbances, disoriented, severe headache, blood pressure high. You expect she will develop eclampsia. Don't wait the patient to have the eclampsia. Give her magnesium sulfate. You must know the vial or the ampoule, what do you have in your clinic. For example, in my clinic, the ampoule is 22.5 gram in 5 ml. I must know how much the ampoule, because you know the company, the pharmacological company, they have different ampoule, different vial. So what we have in our clinic, Asthma Poly Clinic, we have the ampoule, which is 2.5 gram in 5 ml. Please see if it is the same, and I think it is all the same. So we say here, the dose, how much we say the dose is 40 gram, right? So the ampoule is 2.5. I want to prepare 40 grams to be given in 5 to 15 minutes. So please, we say they give magnesium sulfate loading dose. We will prepare 8 ml or 50 magnesium sulfate and 12 ml of normal saline to be given slowly over 5 to 15 or 15 to 20. However, it's from 5 to 20 minutes. You can give the magnesium sulfate. So what I will do, I will draw 8 ml of 50% magnesium sulfate into 12 milliliter syringe to 12 milliliter normal saline. So I will take the syringe and I will put, I will withdraw 8 ml, 40 gram from magnesium, but diluted in normal saline. If not stopped, I will give 2 gram magnesium sulfate. So you have to prepare a syringe in which has normal saline, 12 ml. The syringe is 20. Syringe is 20 ml capacity. You will withdraw 12 ml normal saline and then 8 ml magnesium sulfate in order to prepare 40 gram of 50% magnesium sulfate. So you need at least 2 ampules, and you can withdraw 4 ml from each ampule, so 8 ml. With 12 ml normal saline, the syringe will be 20 ml. So again, you have to monitor vital sign every 15 minutes initially, then every 30 to 60 minutes. For example, if you find the patient has a reduced respiratory rate, less than 16 beats per minute, or batellar reflex are absent, you can give the antidote. The antidote is very important. You have calcium gluconate also, which is 1 gram 10 ml of 10% solution to be given slowly until respiration begin. So please emphasize on the presence of magnesium sulfate, and you must know the dose of this ampule. And you have to prepare also 20 ml syringe in order to fill it with 12 ml normal saline and added 8 ml of magnesium sulfate, and to be given within 5 to 20 minutes. And if you find the patient has respiratory rate less than 16, you have to give calcium gluconate. So again, please, you have to have magnesium sulfate and calcium gluconate in your institutes. And these are the references that I use for this lecture. Thank you very much.